The professional ideas and opinions expressed in this podcast are mine and do not reflect those of any current or past employers. Hello and welcome to the Make It So podcast. I'm Dr. Robert Groves. I'll be your host for this meeting. And with us today, we have one of my favorite people in healthcare, Scott Becker, who has built a real empire in media, law, in business. And Scott, if you wouldn't mind just introducing yourself and saying a few words about how you got where you are.
Sure. No, Robert, Dr. Groves, so nice to be with you. Thank you so much. I always love visiting with you. The empire is a vast overstatement, but I've had the chance to sort of straddle two careers. I was a lawyer by background at a large firm and still have maintained a relationship and a partnership with the firm forever. Been at the same firm in part for 25, 30 years. And then second, about 32, 33 years ago, I started a media company, not with the purpose of being a media company, called Becker's Healthcare. And Becker's Healthcare originally started in one sector and then became a relatively well-known media company across hospitals and health systems, health IT, payers, pharmacy, and other places. And again, the common thread for a lot of things, if you want to build anything or grow a business, is there's no such thing as a solopreneur. At least I'm not that. Everything is driven around teams and working with great people, and then figuring out what you're going to try and be good at and what you're not going to be good at, not what you're not going to do. But yeah, the core of my career has been really law practice in the healthcare setting, and then building a media company that's in the healthcare setting. And it's been a fantastic journey. And the fun of it is really it's things like this, getting to visit with people. I am a person who enjoys people, so getting to know people, getting to talk with people. It just and you first and foremost, though, it's just a pleasure. So thank you, Dr. Gross, for having me on.
Well, thank you, Scott. It really is my pleasure. And I guess I want to start our conversation by, well, first of all, I remember the first podcast we did on an old a podcast that I used to have called The Groves Connection. You said something that really caught my attention. And, I'd been talking to lots of folks in healthcare who had talked about the problem that we have is the fact that, the payment system is messed up and we should be paying more for value. We should have population-based payments and all of these things. And you said something that was, it should be intuitive, I guess, but you said, well, one of the major problems is there aren't enough doctors.
Right.
Can you expound on that a little bit? Do you think the payment system makes any difference at all?
100%. So the payment system is something talked about by politicians, economists, others as a way of solving what is a very clear, simple supply and demand problem more than anything else. So people talk about value-based care. I'll just rant on this for 1 second, and I'll get into the supply and demand issue. People talk about value-based care and it's almost an insult and a narrative that is so off and so insurance company based, and then it's been bought into by everybody. It's almost when something becomes part of a public narrative. Value-based care basically says to a physician who's providing services fee for value, fee for service, that somehow or another that's not providing value. And of course, if you're a physician doing fee for service care, you expect you get paid for what you do. You give the patient good value. That's a physician's view, fee for service of value-based care. Now, the concept of value-based care became this concept of we're going to manage care to try and control the cost. And the reality of managed care, value-based care, fee for service is there are very big problems on both sides of the spectrum. And I don't want to overstate those problems, but my basic concept is, to paraphrase James Carville from a long time ago, it's not the payment system stupid. It's just not. It's just not. If you have what's called managed care, value-based care, and that became so big that now we see the other side of the problem. The other side of the problem is denying care, making it hard to get care, pre-authorizations. Everybody in the value-based care business got rich during COVID for the wrong reason. They got rich because care wasn't being delivered. And it's not to put a knock on the whole industry. There's people that try and do this, and they're really trying to legitimately manage care. God bless them. But this concept that it's the payment system, that if you capitate everybody, that's going to save things. What that does is it leads to the other extreme, denial of care. Fee for service leads to 5% of physicians abusing that program, or hospitals or whoever it is that's providing care and getting paid fee for service. Managed care or value-based care leads to 5-10% of people doing the same thing on the other side. So whatever the payment system is, you're going to have some abuses. It is what it is. The real problem as I see it, and I think the beauty of healthcare, Dr. Groves, is all of us are consumers. You could be a doctor. I could be an observer of the healthcare system. But at the end of the day, every single one of us is a consumer. And there's at some point where we all see the same problems. If I went back 10 years ago, it used to be systems that advertised, we'll get you into our emergency room, our emergency department in 30 minutes. If you remember that, no longer, you're not going to wait more than 30 minutes. Now the average wait time in ERs is 2 or 3 hours. Some places, some states, it's 3.5 hours. And it's really a corollary of supply and demand. We've got 1,100,000 physicians in this country. About 900 to 950 practice truly clinical medicine today. Of that, an increasing percentage are part-time by a certain point. And you see this playing out throughout the system. And I'll go through this in different ways. One is the shortages. You got about half those 950 are primary care, about half are specialists of some sort. At the end of the day, we've lost the war on primary care, and we're in dire straits on specialists. You and I are old enough that we know so many people throughout our lives that have passed away from cancer. And what you find is increasingly it's a different kind of cancer where the bench strength on oncology is so short in our country. It just is. You could think like, oh my God, but so many people have cancer. There are increasingly so few oncologists compared to the amount of people that have cancer. And the people in rare cancers, and they're not all that rare, they're just the depth of the bench, even at the best academic medical centers, save a couple, is so short. So when you have a horrible cancer diagnosis, you're trying to chase down the 3 doctors that can really deal with that. And of those, they're busy. They're very busy. Right, so you've ended up in our country. I was on a podcast with a dermatologist last year. She's one dermatologist for 500,000 people in northern Minnesota. The numbers are daunting. In Texas, I was with a neurologist, one neurologist in an area of 500,000 in a time in our country when you've got increasing diagnosis of dementia, Alzheimer's, and stuff like that. The populist thing, the politician thing was that we need more primary care doctors. At the end of the day, we're never going to have enough primary care doctors, but we've got substitutes. We've got NPs, PAs. Yep. We've got other ways to provide primary care. What we don't have right now is other ways to provide hardcore subspecialty care. And so if I was the czar, we would allocate a lot more of our residency spots. We'd have a lot more residency spots and a lot more to go to specialties. It's an unpopular thing to say, but I believe that, and people don't necessarily love this. I love my primary care doctor. I've had him for 30 years. I love him. What happens is with primary care, though, it's a great indication of the healthcare equity problem and the tiering of the healthcare system. So in terms of the tiering of the healthcare system, we always had these 2 tiers: people that had commercial coverage versus people that had government coverage versus indigent care. We always had tiers. Now you've got this whole evolution of a whole nother set of tiers, which is really built because of the supply-demand imbalance. Now you've got a situation in many states. I think you're in Florida right now. Florida, you can't get a new primary care doctor without paying somebody to be a concierge. And I don't blame the doctor. I don't blame the doctor one bit. It is what it is. They're free. They're free to make a living. The same thing up here. I'm in Chicago. Recently, a cardiology practice ended up going concierge. There's the dermatology practice that's local that has an access fee. And so you've got what used to be a couple tiers of care is now becoming so many tiers of care because our politicians don't focus on the real problem, which is supply and demand and actually providing care.
And in order to increase that supply, it's my understanding, and you probably know more about this than I do, that simply opening up more medical school spots is not going to do it. It's the residency training programs, which are supported by federal dollars, that really need to expand in order for us to increase the supply of docs in the country. Is that right?
That's exactly right. I mean, we produce about 25,000 doctors a year. There's about 10% of people that graduate medical school that don't find a residency matching place. It's central planning 101, where they decided that we need this many residency spots, that many residency spots, and it's really just we do need some of that central planning for residency spots and doctors, but it is really challenging, and there's not enough residency spots. No.
Now, as I recall, and this may have been back in the 80s, that I remember that what the economists were concerned about is supply-based demand. In other words, you go to areas that have more doctors, then you have lots more cost. And so it was a strategy really to try and reduce the number of doctors. And has that backfired on us in the long term? Is that the way you see it?
Well, I think it has horribly. I mean, we've got an aging population that needs more and more care. It's you and I know that when you need to find a doctor in a certain thing, even though when I went to reschedule my primary care annual physical this June, they told me the next date available was last June 25. They told me the next available date for a physical was April 2026. Now, of course, I know my primary care doctor. I've known him since I was a child. He was able to get me in November. But the concept that the next available appointment was 8 to 10 months out is absurd, of course. Yeah. There's always been these issues of, is the supply drive demand? Maybe, but most people can only work so hard. They can only do so many things. I mean, you've got this really challenging situation in our country in that, and I don't know how to solve this. In the 30, 40 years ago, doctors went to all kinds of remote areas. People came out of the military. They came from other countries. They went to small towns. They went to mid-sized towns. Now every doctor and her spouse or his spouse want to go to the top 40, 50 metro areas. And so healthcare in rural areas is really, really challenging. But you start with increasing the supply, and hopefully that leads some people to have to go to other areas to try and make sure they make a living. But I think our supply problem is a disaster.
Now, you have a good look at a lot of the work that's going on and the evolution of technology in healthcare. AI is a hot topic right now. Does that have a chance of helping us at least partially solve this problem, or is that barking up the wrong tree?
No. I think it's helpful for sure. I mean, there's people talk about 2x solution versus 10x solutions, and I'll give you an example. So if your 2x solution is you allow a doctor to provide remote care, he or she can provide care from their home, see more patients, see patients in other places, and so you've leveraged the doctor better. One of my friend's wives is a pediatrician. She is able to, in 3 hours a day, see a lot of patients, never wants to go back to a physician's office, but it leverages her. It doesn't replace her, but it gives her better use of her time, more opportunities. That's different than saying, AI is going to actually diagnose me and I don't need somebody on the other side to check that out. And it's very different based on age range, based on a lot of different things. This Christmas, I went to the urgent care. I had already looked up online what was wrong with me. The online stuff was happened to be, in this case, for a simple diagnosis, 97% correct. I went to the urgent care, the very smart PA confirmed it, put me on antibiotics, a steroid, I got better. But but that's not going to be an answer for, my 75 plus year old. My parents are 87 and 92, and a huge amount of our population is aging. It just, there's places where, of course, artificial intelligence is going to help a great deal, but it's much like triage. It's going to help a great deal on a ton of the smaller things, but we're still going to need doctors and specialists for the harder things. And I'll talk about oncology in a second when let me let you ask the next question.
And I want to get to that, but something else just popped into my head. I was thinking about, and I'd love to hear your perspective on this, but one of the things that I have liked about population-based payments is it does give the care team, and it is team medicine these days. I mean, you can't deliver care without a team anymore. It gives the care team much more flexibility. They can decide how to spend that money. And, some of the New York systems, as I recall, sometimes spend that on hotel rooms for patients that are homeless because it's cost less than putting them up in the hospital, and they can make it safe and they, can get them better. Whereas in a fee-for-service system, there are so many rules and regulations on what you can get reimbursed for that it becomes almost impossibly complex. How do you see that problem? And is there an advantage to population-based payments in that one aspect?
I mean, there can be advantages to it. There can be advantages, but I think what happens is when you talk about giving somebody at the top the dollars to allocate, you end up with, potentially some really good actors that really think about how we're going to allocate them right. other actors that end up being very cautious in how they spend, so things don't get done that should get done. I mean, what's happened is, and of course, you've spent this life sort of at this convergence of the payer and the provider, so you've seen both sides of it.
Yeah.
You know, we used to joke that the only thing you had to teach a medical director at a big payer was how to say no in multiple different languages. We used to joke about that. And the sad thing is, and this is a government created problem. This isn't a payer created problem. This is one of the comedic things that was going on last week was the government lambasting the payers in Congress. You know, the congressional husband. And this is comedic. Why is it comedic? It's comedic because it's the government that has turned over all the healthcare dollars to those payers, both for Medicare Advantage, Medicaid managed care plans throughout the entire country. I mean, the whole ACA, the huge benefit of the ACA is it got us down to only 10% of the community not having coverage. This is a huge win, getting people coverage. But coverage without access is somewhat illusory. We need access to have enough doctors, providers, et cetera. So, I mean, are there benefits to population health if done well? Certainly. You know, but there's but it's whatever payment system you have, there's going to be problems and challenges. But, you know, I was on the phone today with our CEO advisory call, and the more I hear leaders talk about what really counts is how are we providing care to our patients? What are the outcomes we're getting to our patients? And at the end of the day, the idea that we could turn over all the dollars to the insurance companies and this would lead to better care is just a wrong idea. I mean, they're doing exactly what we paid them to do, which is to try and say no, to deny care, to try and cut cost. And again, what's happened is Medicare Advantage, of course, famously now costs more than traditional Medicare, so just not working as it was designed. But this concept that somehow or another, there are population health, the CDC, vaccines. There are plenty of places where population health, public health are so important. You know, I mean, when you get these different narratives going on different sides of the political equation, that somehow or another, you know, the measles vaccine's a bad idea. A lot of these vaccines are bad ideas. And again, you have these convoluted, bastardized things that have happened. Vaccines are generally good. Pharmaceutical companies pushed a button so that now kids are getting a crazy number of vaccines. And there's some reality in between that's probably the right answer. But vaccines are good. Public health and tracking how people are getting sick and not sick and what's going on in the CDC is good. And of course, like any institution, you know, the CDC and the work they do, I think is generally fantastic. It's been for a very long time. You know, some of these organizations get very politicized, like the World Health Organization. I'm, you know, not going down a political, but there's the truth on almost everything is somewhere in between. The one truth I'm a believer in is it's not the payment system. It's ultimately, like when I hear leaders say, our job is to figure out how we take care of patients well, that's the answer. That's the answer. So if Washington would focus on that, and I don't know why they don't. I don't know if it's because the people that are in Congress and Senate, it's either not politically interesting to talk about actually getting care delivered, or if it's because they're immune to it because their families, their people, they get the care and the access they want. I mean, even
they have
now,
the pull that they need to make it happen, essentially. Yeah.
Right, exactly. And it's like, you know, even you and I are involved in the healthcare delivery system in different ways. We have access to people that can help us get to the right person. But even so, we know we can't ask all the time without being like, you know, without driving those people crazy. And even those people that have access to the access are basically finding themselves in a tighter and tighter spot because we just don't have enough doctors. And, you know, it's like, yes, getting the urgent care visit at the wherever and taking care of the cold or the flu, absolutely fine. Taking care of the cold or flu for your 90-year-old parent, more complicated. And when somebody has a cancer diagnosis, what's happened now, there's this whole evolution of businesses around almost concierging cancer care because the oncologists are just totally overwhelmed.
It seems so complex at times that I just want to throw up my hands and say, I don't even know where to begin. But I've got several other topics I'd love to cover with you. I want to get to oncology, and I want to touch on your book that I understand is coming out in June. But before we go there, let me just ask one more question that I'd be delighted to get your insight on, and that is, do you believe that it's the shortage of providers that is driving, let's just say, the majority of the rise in healthcare costs, or is that also much more complicated?
No, I don't think that's what's driving the rise in healthcare costs. I think that's a piece of it. The physician piece of the entire pie is ridiculously small.
That's access, really.
Yes, yeah. It's access, but I don't think that's what's driving the cost. I think it's driving the access problem, and I think the thing that you said a moment ago is so important, though, and people have to recognize this. Like, when you look at, we have 350 million people in our country. We're the third largest country in the world after China and India. So when people say, oh, it's simple, we should just do what Sweden does or just does what Vermont does, I mean, they're really sort of like politically undercomplicating the issue, because it is a complex system. We have a heterogeneous, we have a very varied community, 350 million people. It is a very complex problem. It is. And what happens is when people compare it to, like, well, if we just had medicine like they have in Vermont, or just had medicine like they have in Sweden or Finland, they're oversimplifying on the other side. And then China and India is where we don't want to be. China and India thought they could solve it through preventive care, through other things. And if you look at COVID, it was a disaster in those countries. Like, we had our problems here, no doubt. In China, they literally didn't have enough doctors and nurses. So the strategy was, let's lock everybody up so people don't get contagious. And in India, they just got overridden because they just don't have enough doctors and nurses. So when we talk about AI, you talk about technology, you talk about prevention, all great, but it's trust plus verify. Verify means having enough doctors and nurses to take care of people. We've done a great job in our country of quickly accelerating how we educate nurses over the last few years. It's really remarkable what's been done on the nursing side. We turn out 185,000 nurses a year right now, 175 to 200,000. That's way up from a few years ago. We've expedited nursing education. It's imperfect, but it's fantastic what they've done. On the doctor side, we're still stuck in 50 years ago, where the education system was developed prior to the internet, and it's just a disaster. We have a stepdaughter who's in medical school now, 4 years of college, 4 years of medical school, 4 years of residency, fellowship. By the time somebody's out practicing, they're 32, and half are part-time, not half, but a good percent are part-time by 40. I mean, it's literally an insane system. And the answer is, in other countries, they're doing it quicker. In other countries, we are the beneficiary of countries that are turning out doctors by 27, 28, and they're some of our best doctors in our country. So it's not like it's not doable. It's being done.
Yeah. I want to get to let's talk about oncology a little bit. I mean, the drivers that particularly in large health systems, the three categories that tend to help pay for everything else are what? Orthopedics, cardiovascular, and oncology, right? Those are the ways
Absolutely.
Systems get their money so that they can justify having a level 1 trauma center or whatever. So let's talk about oncology a little bit. I know you had some insights on that you wanted to share, and I'm interested in your perspective there.
Yeah, but I would come back to cardiovascular, oncology, orthopedics. It's, at the end of the day, cardiovascular and oncology and cancer are the two largest causes of death in our country. And so the allocation of resources to those, people could blame it on the payment system, they can blame it on this. I mean, you and I know that when anything new is getting built in a system, it often revolves around those three things: oncology, cardiology, orthopedics. And there's good business reasons for it, and there's good community need reasons for it too. I mean, a few years ago, the pendulum swung the other direction, where everybody's talking about how do we create a value-based care system, or this system, or that system. Now you've got people investing in technology for sure, but also, again, cardiovascular institutes, orthopedic institutes, oncology and cancer centers. But it is where a lot of the need is, in addition to where the money is.
I must say, also, neurology is coming up fast with the Alzheimer's crisis, so I don't want to leave that out.
Alzheimer's, dementia, and so forth. And this is a great spot where the need and the money doesn't line up, where the need and the supply doesn't line up. We're incredibly short of neurologists in our country, incredibly short of psychiatrists in our country, which is an offshoot behavioral health versus, but incredibly short and not getting any better anytime soon. Oncology is a debacle, and again, and that's not to say. And again, like many things, a debacle is a fast overstatement. We do so many great things for so many people on the preventive side today, so many great things in terms of screening early, so many great things in taking care of so many cancers, and we've driven down the mortality rate in so many cancers. At the same time, you've got mortality rates in colorectal, pancreatic, brain cancer that have not changed and are going in the wrong direction. I think colorectal cancer now is going to be the second leading cause of cancer deaths by a certain age for younger people than it was ever before. You've got so many cancers that are not going in the right direction and so many that are. So it's not, but what I see is when we see a bad outcome, and you and I are old enough to know plenty of people that have had bad outcomes from cancer. We had a colleague this past year who passed away who, ended up with melanoma of the eye. There's 3 people in the country that know anything about that, or a few more than that. And that person you can't find half the time. So the person went through all the processes, all the clinical trials, sadly passed away. Friend with pancreatic cancer last year passed away. There's certainly these cancers that remain death sentences. A nephew with brain cancer that passed away. And what you find in watching these close family members and close friends that have bad cancers is you learn very quickly that the bench is very short in our country.
Yeah.
Once you get something that's a significant, serious, one of the more challenging diseases. And obviously, brain cancer, pancreatic cancer remain horrible timelines. Melanoma of the eye, which another friend had, also horrible timelines on those. But it's very scary. But what you really learn, it's not so much that it's scary diagnosis or prognosis, it is. But you learn how narrow the bench is in oncology in our country. So it's like somebody today called related to a close family member, and the person's got a rare form of cancer. And so what do? They start at the academic medical institution in our area. Then they look at Mayo, MD Anderson, other places. And then there's all these services that have evolved, private health management, which you talk about the concierge, the tiering of healthcare. Very, very bright people, a ton of PhDs that help steer people through cancer. Where's the best place to go? Who's got the best clinical trial? Who's got this? Who's got that? And no commercial relationship with them at all, but I've grown to respect what they do. Zero. But there's a need because every oncologist, once you get past the basic cancers that are relatively treatable, prostate, breast cancer, colon cancer, if you catch it early enough, it's once you get past those, oncologists are overwhelmed and they can't keep up with the information flow. They just can't do it. It's literally impossible.
Yeah. And as you pointed out earlier, it's not much better in neurology. It's not much better. It's no better in behavioral health. It's just across the board. So you're an investor too.
Some.
But the reason I bring that up is because you obviously are looking at what's out there and what might have some promise for making things better. Where are you directing your attention these days? What kinds of companies do you think have a chance of making this better?
Yeah. So here's where I start as an investor, and this is a fair question, but I'm going to have an unfair answer. So bear with me on this.
Okay, all right.
Bear with me on this. And the reason I say that is I can never tell which science is going to end up being the science that ends up winning a certain spot. I can't tell which biotech company is going to win, which med device company is going to win, and I can't tell which health technology company is going to win. Because people will say to me, can you review our technology, can you review our deck? And I'm a lawyer, a media person, a publisher, an observer, thinker, speaker. I'm not a technology person, so I can't tell you. I'm not a biotech guy, so I can't tell you. What I do know is that for me, I end up trying to do, most of my investments is index funds and treasuries, so bear with me on that. But when I get into the stuff, when I get into the stuff that's more interesting, I try and invest directly with people that know that stuff. and then you're hoping for the best. So I invest with
Yeah.
venture capital funds like Andreessen Horowitz. I invest with private equity funds that are in the healthcare business, but I don't have the data to decide, that's going to be the next thing. I mean, there's people that spend 24/7 doing that, and they don't know. There's all these things about.
That is an extremely fair answer. I'll suggest, and in fact, it's probably why you still have some money.
Right.
Is you're investing in people really that
100%.
That have the information, and that brings us to the next topic that I wanted to make sure that we had plenty of time to cover. And you've got. I've already pre-ordered it, and I'm excited about it. You got a book coming out in June about building businesses. Tell us the name of that book and what prompted you to write it, and then let's dig in a little bit about.
Thank you.
And investing in people is one of the things that I remember about some of the blurbs that I've seen about it. Is that picking the right people for your team is one of the major keys to success. But I'll let you.
I think that's right. I think that's right in everything is sorting out the right people, getting the right people, investing in the right people, doubling down on the right people. I think that's everything. I mean, you find things that work, you double down on those, you try and keep it as simple as you can. But the book is called Building Great Businesses, Create Momentum, Overcome Setbacks, and Scale with Confidence. And it comes from a lifetime of building a legal practice and building a healthcare media company, and then investing and serving on boards of directors of numerous different companies,
yes.
and investing with some private equity funds, investing in some companies. And again, anybody who is probably straightforward about this will tell you that they've had successes and failures in those things. It's a constant learning experience. And so like many, I've invested in companies that have gone broke. The smartest thing I do is keep only a small allocation of my total amount that I can invest in higher risk things. But it was in a deal that thought was going to be a home run. They ended up merging into something, made almost nothing, and lost most of what. You're going to have some of those, and I think that the concept of the book is was originally built to put my ideas on business and investing in one place, really as much as anything for my children. So this book that's coming out now for my children, and they have a place for me to categorize where my thoughts are and stuff like that. So this book that's coming out now is really in some ways, I'm an incremental person by nature. I just really am. So I did a first book several years ago to really try and collect these thoughts. It turned out awful. We trashed it. We went and redid it. Did a second book called The Entrepreneur's Edge a couple years ago. That was better. That was at least a B plus, B minus. I don't know where you would put it, but better. Then I went back about a year or so ago and got professional advice on, okay, if I wanted to turn this into a real book that people would actually read and enjoy versus just 70 different chapters that have a different thought per chapter, which I like that format fine, and it's solid and fine. I got professional advice on it, then went back and wrote a book last summer that goes through this building businesses concept, and it took out all the investment thoughts, went into really about building businesses. It was a great project for me. One of the things, as you know, is constantly keeping ourselves project oriented, building oriented, physically and mentally healthy, and so it was a great project for me. And then worked on it with I wrote it. One of my editors co-edited it with me, Molly Gamble, who's worked with Beggars Healthcare for a long time. And then we have a professional publisher who's working on cleaning it up and ready to go. And so, no, it's just, I'm a big fan of, on one hand, I'm a big fan of that we want to motivate people, teach people, entertain people, hope they enjoy it, help they get something from it. I'm a believer that if you and I talk for an hour, if the only thing somebody comes away with this from is a little bit more motivated, a little bit more inspired, a little bit more excited about what they're doing, then that's the biggest win we could have. There's, very few of us, and I'm not, are genius, like, oh my God, that idea is going to change your life. I don't think so. Hopefully you come away reading it a little bit motivated, a little entertained, a little bit like, oh, I could see where, I'm not, we've built successful businesses. We've been involved in successful businesses. we're not so different than the average person, so we hope people come away with it with a little bit of excitement, a little bit of enthusiasm, and also understand if you want to do it successfully, it takes a lot of work and a lot of energy and building great teams, obviously. So that was the gist of it. And we enjoyed the whole process of really last summer, spent 3 months doing nothing but writing for, several hours a day and enjoyed it a great deal, and had to get back to my day job and work and do all the things I do.
But I have to ask, did you use any large language models in helping you put it together?
I did not. When I did this last summer, that concept was just starting to evolve. People were just starting to evolve on it, and so I use, there's, we talk about this daily in artificial intelligence, because I use AI every single day now and looking at something on ChatGPT or doing questions. If I do several podcasts a day. I used to give people standard questions. Now I more and more drafting questions for people, and I hit ChatGPT and it does a great job of it. And I don't know what that's going to mean for authoring real books, real things. I know that now when somebody writes an essay, like one of my kids writes an essay for college or for business or for anything, people could tell if it's written by them or written by ChatGPT or not. The book, of course, will have all my flaws, so people will be pretty clear that's not written by ChatGPT or something like that. It's just not. But it's an evolution of I'd like to write another book. I wrote several of them early on in my career at the intersections of healthcare and business. So it's not like I've written several. They're all I didn't think I would do it again until I got the bug to do it again a few years ago, because it was daunting when I did it originally. It was really a full-time effort. It's still a full-time effort. Certainly AI is going to change that for people. And then it'll be a matter of, does it still come out feeling authentic and real?
Yeah.
And I don't know, you and I have favorite authors, and some of those favorite authors, whoever they are, that are your favorite authors, my favorite authors, we could tell when whoever or however they do it, they've put real effort into it and it's really thoughtfully done. And other times when it's sort of, they just obviously just got it out, and so I don't know. I don't know where that will evolve to, but this one was not really like that. So all the flaws were written by me directly.
Well, that makes it all the more valuable, in my opinion. So
I hope so.
I'm really looking forward to that release. Are there any overarching themes or life lessons in the book that you would point to and say, this is what I hope you take home?
Yeah, I think that the other book that I did went into a lot more of that versus direct business. So we had a whole chapter on, so for example, we admire tremendously these people that are in their mid 80s and still playing tennis, still playing sports, still active and stuff like that. And there's a chapter we had in the old book called Active Until Your 80s. There are life lessons about, if you're a careerist, as you're developing your career, the most important thing is deciding what you want to do with your career, not what somebody wants you to do with your career, what you want to do with your career. So there's a lot of those life lessons. There's some of those play into this book. Like we're a believer that if you're going to build a business, I've never been able to do it without being obsessed about doing it. And so it's not easy. It's like people, it's not easy. And, when you don't have that, and I've never been able to do it without building teams. I've tried, because obviously if you've built businesses with large teams, our law firms got thousands of employees, media companies got more than 100 employees. If you built businesses, one of the dreams is, okay, how do you build a real business with 3 employees versus 200 versus 10,000? And I've never been able to do that. I mean, I'm a believer that you still need, anything serious you're going to do still requires you with other people and great leaders. We're also a believer, I guess one thought that I do think is a life lesson. One of the thoughts we think about with teams and people is this concept of thrive. And this is, I think, a life lesson that is big in this book too, that if you have teammates that you're working with, whatever they do, however they do it, they need to thrive as well as the organization thriving. And it's generally not going to be 100% overlap. So as a leader, as a CEO, as a boss, as whatever you are, if somebody's doing a fantastic job and they're trying to make themselves a superstar too, that may not be at the moment what the company needs, but it's that thrive concept. You want them to be stars as well as the company to be stars. We're a believer in that. And the other life lesson that I think I love that is discussed in this book too, I'm glad you jogged my memory on this, we have a concept called love your 90 percenters. And this came out of business and life, watching some bosses just beat up their people over the 5-7% they don't do perfectly. And my perspective is you're far better off letting your 90 percenters thrive, people that do 90% of what they're supposed to do great. Love them, embrace them, enjoy it, love it, and don't worry about that 5% unless it's so bad that's going to kill their career, and then you got to have to talk, discuss about them, with them about that. So those are two things that sort of...
It reminds me of another principle that I heard about and tried to implement the best of my ability early on, and that is, do those things that you yourself are good at and get very good at those. They're the things that you enjoy, have a propensity to do those things really, really well, and then surround yourself with people who can make the weaknesses irrelevant. Does that make sense to you?
100%. No, I'm a huge fan of you double down on what you're good at, you double down on what your people are good at, you don't fight it. I played tennis. If I spent my entire life trying to be a great server, I'd probably not be a great server. I've got to be adequate. I've got to be good enough to compete and not get my serve beaten up. But if I tried my entire life practicing to be a great server, I probably wouldn't be. If I spent a little more time working on my forehand, working on a couple other things, there's immediate benefits to it, and it has an impact on how I play. So, I think you got to know what's important. But I think we're a huge fan of that strength-based living. It's you double down on your strengths. You know what your strengths are. You double down. We believe it's the same thing in organizations.
Absolutely. It has been a great pleasure. We have one question that we're asking every guest, and it's based on the name of the podcast. The name of the podcast I stole from Star Trek: The Next Generation. It's called Make It So. And so if you could do one thing, and it can be political, it can be business, if you could do one thing to change the trajectory of healthcare, turn it around and head it in the right direction, what would it be and how would you make it so?
Oh, that's a great question. I thought we were going to be able to go back to this concept of having DC being a problem-solving environment, trying to solve problems versus trying to fight with each other. Make it so in healthcare. I start a lot with, how do we fix this issue of the shortage of doctors and nurses? And people will say that I'm fighting yesterday's battle, that by the time we fight it like the Maginot Line, it's going to be irrelevant. But I don't think that's right. I think we're going to need enough doctors and nurses to take care of us. And we've got to fix medical education. We got to fix the number of specialists that we're turning out. We've got to get more of them turned out. We got to get the best and brightest being in those specialties. I mean, I've not answered your question, but I do think so many of our problems in terms of actually caring for our people are based on workforce challenges, workforce problems, and so forth. And technology is a huge part of the solution, but we still need great people, and we need the best and brightest. We don't need the best and brightest going into investment banking. God bless them for doing so. They're allowed to. Everybody should be able to do whatever they want, but we could use more of the best and brightest, being physician scientists, researchers, et cetera, trying to fix things and solve things for people. So.
Yeah. Is anybody else beating that drum besides you?
I think there's more and more people beating that drum, but it's certainly not part of the core discussion and narrative out there. I mean, every medical school dean that you talk to, and I talk to a lot of them, understands that medical education is sort of screwed up. It's not. We produce great doctors. We just do so horribly inefficiently and horribly expensively, and over a much longer period of time. So I do see there's a guy that runs an institution, Northeast Ohio Medical School. They've done, it's called NEOMED. They've done an incredible job of trying to amp up all kinds of allied professional education and trying to move things along faster. They've just done an incredible job. And there's places doing it for sure. I do have great concern that, I'm the NHI funding, we needed our great research institutions. We need more of it. But it's also, you do need some watching of how it's spent, but we need that money badly to continue to be great on the academic side. Here's the great academic medical centers. I hear them saying we have to spend more time doing other things. And my view of the world is no. We need you being great at what you're great at. and they need the
absolutely.
NHA funding to do that stuff. We don't, I mean, there's a lot of commodity healthcare. We actually need our academic medical centers being fantastic at what they do.
Absolutely. I think we'll wrap it up there, Scott. What a great pleasure it's been. Where can people find out more about your businesses and what you're doing? Where would you send them to learn more about your companies?
Yeah, no, I think the easiest thing is probably to find me. Scott Becker on LinkedIn is probably the easiest place. People are always free to text 773-766-5322. Obviously, love people to go on Amazon, pre-order the book. I've got a whole education in the book business. It's building great businesses, great momentum, overcome setbacks, scale with confidence. And again, we hope you get something out of it. This is not Peter Drucker. This is not one of the great books of all time, but I think it'll be really helpful to a lot of people.
Well, I'm excited to read it. Thank you so much for spending your precious time with me today. I really do appreciate it, Scott. It's always a joy, and I mean that sincerely, a joy to talk to you. I always come away inspired. So thank you very much. And everybody, we will see you next time on Make It So.
Dr. Groves, thank you so much for having me. What a pleasure.